This is the lecture on cardiac anatomy and physiology. First things first, we're going to study the location of the heart and define a few terms. What is anatomy? Anatomy is the study of structure rather. What is physiology? It's a study of function. And we study anatomy and physiology together because biological systems are designed specifically for efficient function, a concept that would hold true to all systems. We will study the structure of the heart and the surrounding blood vessels. When we describe structure, we should talk about its location first. The heart is located within the chest, under the sternum, or substernally, as we would say with medical terminology, between the lungs, and bordered inferiorly by the diaphragm. The space is called the mediastinum. That's the space between the lungs. The mass of the heart, 2/3 of it rather, is pointed left of the midline. If you'd notice here, many of the diagrams that I use are from different textbooks, and you'll see figure 1.1 here, the location of the heart in the chest. It says the heart lies in the space between the lungs, in the middle of the chest, and it sits behind the sternum, just above the diaphragm. So the sternum is the breastbone, and it basically joins the rib cages together. The diaphragm, of course, is the major muscle of breathing. I want to introduce you to an important concept here. The pointed or free end of the heart is called the apex. That's the pointed end of the heart. And the base is the part of the heart that is connected to the blood vessels. If you'd notice that the apex is between the 5th and 6th rib, and the point of attachment is at about the 2nd rib. And this is kind of counterintuitive because normally we would find the base, say for example, of a structure or building is at the bottom. But the concept is the base is the point of attachment. So we're going to take a quick overview of the structure of the heart here, and I like to go by the numbers. The heart is basically a hollow muscular organ. It's composed of the following: a sac called the pericardium, 3 layers, 2 septa, 2 sides, that form 2 pumping circuits. The concept is the septa separates the heart into left and right sides that form the 2 pumping circuits. 4 chambers, 4 valves, and 8 attached blood vessels. I find remembering the numbers or taking it by numbers in this particular sequence helps students remember all the structures of the heart. Now we're going to talk about the pericardium. It's basically a fluid-filled sac. The outer wall is the hard wall. It's the fibrous pericardium. The inner wall is a thinner layer that is the visceral pericardium. In between the 2 walls we have some serous fluid. Serous fluid is clear to yellowish fluid that fills the walls. The visceral pericardium actually is continuous with the outer layer of the heart called the epicardium. Within the epicardium we have the coronary arteries and fat deposits. You might ask yourself, why are there fat deposits on the outside of the heart? It is actually a vestigial effect from the thymus gland. After you reach age 25, the thymus no longer exists. It atrophies into fat. And also the fat is actually it's got a bad reputation, but it actually functions to cushion some of the walls of the heart. On this slide here, we're basically applying what we learned from medical terminology. We're breaking apart the term pericardium and the term epicardium. When we look at the following diagram, we can see the 3 layers starting from the outside, the parietal pericardium. We see the pericardial cavity with the pericardial fluid, and we see the visceral pericardium that actually is attached to the epicardium. The pericardium functions to enclose and protect the heart and anchor it to the blood vessels. The pericardium is attached by ligaments to the spine and diaphragm. The function of the pericardial fluid, as I said before, is lubrication. It prevents the two surfaces from rubbing together. And you'd notice that the endocardium is not smooth. It contains muscular ridges. The names actually is beyond your scope of study. And as with other lectures that I've posted on YouTube, you'll find that I give you more information than I'm usually testing on. But, it's up to you whether or not you want to assimilate that information and use it later on. Just to drive home the concept and your understanding of what the serous fluid does, I present you with a question, what other structures in the body contain serous fluid, and the answer are joints. Basically because joints need lubrication as well. In the joints, we call them that particular serous fluid synovial fluid. The second layer of the heart is the thickest layer. It is the myocardium. It is the functional layer and is made of cardiac muscle. This cardiac muscle contracts to pump the blood. The endocardium is the innermost layer, the part of the heart that is in contact with the blood that's being pumped. It lines the inside of the heart, it lines the valves, and it also forms a continuous layer for the inner lining of the blood vessels. Here you're going to see table 1.1. It's basically me presenting the information in a different way. I find that if I present the information at least twice to you or in different formats, it kind of helps your understanding of it. So you'd see the epicardium, myocardium, and endocardium all listed here and their functions. Additionally listed in this slide, you'll find the special property of myocardial cells, automaticity. That is the ability to make an electrical impulse. In some textbooks, it's described as the ability to self-excite. In other words, these are muscle cells that tend to make electricity. They act like nerve cells. Conductivity, the ability to conduct an impulse from one cell to another. This is in contrast to skeletal muscle that are wrapped in fascia and insulated from one another. One part of the heart can actually receive an electrical impulse and spread it to a different part of the heart. Contractility is the ability to contract or shorten in response to a stimulus that's common to all muscle. And irritability or excitability is the ability to depolarize. Depolarize is a fancy term. 99% of the time, depolarization is synonymous with contraction. Of course, there is one exception. And irritability or excitability, the ability to depolarize in response to an outside stimulus. Okay, let's talk about the four chambers of the heart. Two upper chambers receive blood, the right and left atria. Singular, it's pronounced atrium. Think of it like the atrium of a building or museum. That's the entrance, or as it's commonly known, the lobby. All blood enters the heart via the atria. The two lower pumping chambers are called the ventricles. We have the right ventricle and the left ventricle. Before we continue talking about the chambers of the heart, we're going to talk about the septa. The right atrium and right ventricle are separated from the left ventricle and left atrium by a piece of muscle called the septum, or plural, septa. The piece of muscle between the right atrium and left atrium is called the interatrial septum. There's a thicker piece of muscle that separates the right ventricle from the left ventricle, and that's called the interventricular septum. Let's take a look at how blood flows within the chambers themselves. Blood flows into the heart via the right atrium, and the right atrium pumps this blood into the right ventricle. So the blood flows from the atria to the ventricle. The right ventricle then pumps this blood out of the heart. Simultaneously, blood flows into the left side of the heart. It comes in via the left atrium. The left atrium pumps this blood into the left ventricle, and the left ventricle pumps this blood out of the heart. So in summary, the atria are the receiving chambers. Once they get the blood, it's pumped into the ventricles, and then the ventricles pump the blood out of the heart. As long as we're on the topic of blood flow, we're going to talk about a few blood vessels, just the basics. Blood vessels that bring blood to the heart are called veins. Blood vessels that take blood away from the heart are called arteries. Therefore, veins are attached to the atria since they are the receiving chamber. In other words, veins empty into the atria. Veins take blood to the heart, therefore they empty into the atria. Arteries, on the other hand, are attached to the ventricles. The ventricles pump the blood out of the heart, and therefore arteries are attached to them to take blood away from the heart. Just want to do a quick summary here. So veins bring blood to the heart, and veins empty into the atria, the right and left atria. The right and left atria pumps this blood into the pumping chambers, the right and left ventricles. The right and left ventricles pump blood out of the heart into the arteries. So we're going to talk a little bit more in depth about the left and right sides of the heart. So the left and right sides of the heart pump blood to different parts of the body. The left and right sides, of course, again, are separated by the septum. So blood is not mixing. Blood from the left side is not mixing with blood from the right side. That's the function of the septum. Again, we're repeating the muscle that separates the right and left atria is called the interatrial septum, while the intraventricular septum separates the right and left ventricles. So I've presented this information now twice to you just to kind of bring it home. Where else in the body is there a structure called a septum? Just for you to remember your medical terminology, we know that in the nose, the septum separates the left and right nostrils. Let's talk about the circulation on the right side of the heart. So blood that's received on the right side of the heart is pumped from the atrium into the right ventricle, and the right ventricle pumps this blood into an artery that takes it to the lungs. Blood comes into the left side of the heart from veins that empty into the left atrium. Left atrium pumps that blood into the left ventricle. The left ventricle now pumps that blood via an artery to the rest of the body. Since the blood on the right side is only pumped to the lungs, it is called a pulmonary or pulmonic circulation. Since blood on the left side is pumped to the body's organs, it's called the systemic circulation because it goes to the body's systems. At this point, you should know the difference between the right and left circulations of the heart. Now we're going to talk about the condition of the blood that's being pumped. Blood from the right side of the heart is deoxygenated or oxygen poor and is pumped to the lungs to pick up oxygen. Then it flows to the left side of the heart. From the left side, this blood is now rich in oxygen. It is pumped to the body's systems, so some oxygen exchange can take place. The body's tissues needs oxygen, and it needs to get rid of carbon dioxide. So therefore, this blood now goes to the body's systems, exchanges its oxygen for carbon dioxide. Now that blood is oxygen poor, and it returns to the right side of the heart, completing the circuit. If you look carefully at the simple diagram there, it should become clear. Valves, just like in plumbing, ensure that water, or in this case blood, flows in one direction only. They open and close in response to changes in pressure in the chambers or blood vessels. So there are two types of valves. The AV valves, also known as the atrioventricular valves, they're within the heart itself, and they separate the atria and the ventricles. That's why they're called atrioventricular. The one on the right side is called the tricuspid valve. Now, how would you remember that? TRI for tricuspid, and RIGHT spells right. Therefore, the tricuspid is on the right side. The bicuspid valve is on the left side of the heart. Another name for the bicuspid valve is the mitral valve. Actually, clinically, the bicuspid valve is always called the mitral valve. Here we have a picture of the heart in transverse section, and we're looking at it from a superior view just to show the position of the valves, and it shows the tricuspid valves. It has three cusps, and the mitral valve actually only has two, hence the name. The purpose of these valves are to prevent the backflow of blood into the atria. So these are AV valves. Remember, they're between the atria and the ventricles. So when the ventricles pump, it prevents blood from flowing backwards into the atria, ensuring that blood flows in one direction only. This diagram shows us the two AV valves are actually connected to tendons, which are actually connected to muscles within the heart itself. Once these muscles tense, the valves remain closed, they remain shut. When these muscles relax, the valve opens. This is the diagram that you were given in the handout. It clearly shows the relationship between the atrium, the ventricle, the AV valves, and actually another type of valve called the semilunar valve. If you notice, the pulmonic valve is pictured there. The pulmonic valve is a semilunar valve. It's located within a blood vessel itself, and that's what semilunar valves are. They're located within blood vessels. The pulmonary valve or pulmonic valve is located within the pulmonary artery, and the aortic valve, which is not pictured here, is actually located in the aorta. But I want you to study this diagram carefully because it shows the relationship between the atria, ventricles, the valves, the attached blood vessels, and it also has a good picture of the intraventricular septum. Okay, if you notice the structure of the heart from all the diagrams that I've given you so far, the ventricles are on the bottom of the heart. The main pumping chambers are on the bottom of the heart. The receiving chambers are on the top. The ventricle actually pumps blood in an upward direction. In other words, blood exits the heart out of its base. The base of the heart, in this case, is at the top, against the force of gravity. Therefore, when the ventricles squeeze the blood leaves the heart. However, we have another problem to deal with. When the ventricles relax, there's a tendency for gravity to pull the blood back down towards the ventricles. How do we prevent blood from flowing back down to the ventricles? The answer are the semilunar valves. Semilunar means half moon, and when the ventricles relax, these valves are actually forced closed by the slight backflow of blood. Again, two semilunar valves are the pulmonic valve in the pulmonary artery and the aortic valve in the aorta. This is an excellent diagram here that I found for you, that I scoured actually the internet for, and it shows you the function of a normal valve. It tells you the heart beats, the valve open, blood flows one way through the valve. The heartbeat ends, the valve shuts, briefly stopping the flow of blood backwards. Again, I like to present material to you in different forms and different formats to facilitate learning from different learning styles. So here it is in a tabular format. The AV valves, of course, are the tricuspid and the mitral valve, and the locations, and the semilunar valves are the pulmonic and aortic valves, and also their locations are listed here. There are 8 blood vessels that are attached to the heart, and if we divide them up into arteries and veins, that might help. It's less complicated than it first seems. We're going to actually tackle some important differences between arteries and veins. I'm presenting this information once again, just in case you've missed it. Arteries carry blood away from the heart, and they're thicker than veins. Veins carry blood back to the heart, and veins are generally more stretchy. As a matter of fact, at any given moment in time in your body, about roughly 60% of your blood is within the veins themselves. Blood flowing through arteries has just been pumped out of the heart and is therefore under much more pressure. Arteries are thicker to withstand this pressure, and they're also very elastic to compensate for relaxation and contraction of the heart. Therefore, the blood flow in arteries is what we call pulsatile. It follows the heartbeat. When the heart pumps the blood, you get a huge gush of blood flowing through the arteries. When it relaxes, the pressure also relaxes. While we're on the subject, we can talk a little bit about blood pressure. Blood pressure is a measure of the pressure of blood against the walls of an artery. It has nothing to do with heart rate. A lot of people get them confused. In a blood pressure reading of 120 over 80 millimeters of mercury, that's what mmHg stands for. 120 represents the pressure against the artery wall when the heart contracts. 80 represents the pressure against the artery wall when the heart relaxes. The medical term for contraction and relaxation is systole for contraction, diastole for relaxation. So that's why you will hear the top number referred to as systolic blood pressure and the bottom number referred to as diastolic blood pressure. Here's an excellent picture showing you the difference between an artery, capillary, and a vein. Now, capillaries are microscopic and they're exchange vessels. Without capillaries, we couldn't exchange oxygen for carbon dioxide and nutrients for waste. You see the thickness of the artery wall, and you see also the difference between an artery and a vein. So again, I encourage you to remember that veins bring blood back to the heart and arteries take blood away from the heart. So we're going to start on the right side of the heart. We're going to talk about the right atrium receives blood from the inferior vena cava and the superior vena cava. If you look on this diagram, there are large blue blood vessels that connect to the right atrium, and you see the two blue arrows coming in. Of course, the superior vena cava is on the top and the inferior vena cava is on the bottom. To answer the question, of course, the blood is coming from the body. It's spent or used blood, for lack of a better term. It's really just deoxygenated. In other words, it's oxygen depleted. That's why it's colored in blue. Generally, in these heart diagrams, anything that's colored in blue contains deoxygenated blood. On the left side, the left atrium receives blood from the pulmonary veins. Pulmonary veins, there are 4 of them, 2 sets from each lung, 2 sets from the right lung, 2 sets from the left lung. This blood is rich in oxygen. Okay, so just repeating that, and of course I'm throwing another diagram at you here. I've searched for diagrams that I have actually presented this information in a much clearer context. Remember that veins connect to the receiving chambers of the heart, the atria. On the right side, we have blood coming into the atria from the IVC and SVC. That's the right side of the heart. On the left side of the heart, we have 4 pulmonary veins from the lungs, 2 from the left side, 2 from the right side. So if we remember that the heart has attached to it 8 blood vessels, we've already covered 6 of the blood vessels. So therefore our task isn't as daunting. The last 2 blood vessels are the aorta and the pulmonary artery. So these are both arteries. The aorta is the largest artery in the body. The pulmonary artery is an artery that takes blood to the lungs. Anytime you hear the term pulmonary, think lungs. The pulmonary veins bring blood from the lungs. The pulmonary artery takes blood to the lungs. If you recall when we spoke of the different systemic, if we recall when we spoke of the 2 different circuits or circulations of the heart, that the right side was involved with the pulmonary circulation. Therefore, the right ventricle is connected to the pulmonary artery, which splits into, you see that T-like structure there, it's called the pulmonary trunk. It lies below the aortic arch. The left side of the heart, the left ventricle, is connected to the aorta. The aorta actually goes over the pulmonary trunk, and it splits in three places. The aorta is the largest blood vessel in the body. It's the largest artery in the body. If we were to receive an injury to the aorta, a patient can actually bleed out in a matter of seconds. Okay, now that we're familiar with the anatomy of the heart, we're going to try to trace a drop of blood throughout the body. Just a quick review. Remember that veins bring blood back to the heart. They empty into the atria. The atria pumps that blood into the ventricles. The ventricles pump that blood out of the heart into arteries. You just have to remember the name of the arteries and the name of the valves that separate the atria from the ventricles, and the name of the valves that separate the ventricles from the blood vessels. We're going to start in the lower extremity in the leg. So remember that the blood in the leg will be deoxygenated, and it would be returning to the heart. It would enter the right atrium via the inferior vena cava. Now, conversely, if we were talking about, say, blood in the shoulders or arms or upper extremities, it would be returning to the heart via the superior vena cava, or SVC. So blood from the leg would be deoxygenated when returning to the heart. It would enter the right atrium via the inferior vena cava. It would flow past the tricuspid valve into the right ventricle. When the right ventricle contracts, it would be pumped into the pulmonary artery past the pulmonary valve and transported to the lungs. At the lungs, it would pick up oxygen and start making its way back to the heart via the pulmonary veins. That would complete the pulmonary circulation. Blood from the pulmonary veins empties into the left atrium. It flows past the mitral valve into the left ventricle. When the left ventricle contracts, blood is pumped into the aorta. The blood flows past the aortic valve and is carried to the rest of the body. Just in case you missed any of that, I'm going to summarize it for you. Deoxygenated blood, that is oxygen poor blood, comes to the heart via the inferior vena cava and superior vena cava. Deoxygenated blood is received in the heart by the right atrium. Deoxygenated blood flows past the tricuspid valve from the right atrium into the right ventricle. Deoxygenated blood is pumped into the pulmonary artery, bypassing the pulmonic valve. That right there is the pulmonary or pulmonic circuit. Blood picks up oxygen and returns to the heart via the pulmonary veins from the lungs. The blood is now oxygenated. Oxygenated blood returns to the left atrium and flows past the mitral valve. Oxygenated blood is pumped into the aorta by the left ventricle, past the aortic valve, and returns to the body. Here's a pictorial representation of everything I just said. It will be helpful if you note A and B, and you note the colors. Blue represents deoxygenated blood, and red represents oxygenated blood. The yellow is the ultimate fate of the blood. It says lung tissues / pulmonary circulation, and body tissues, that's the systemic circulation. I encourage you to go over this diagram in detail because it covers all the structures that we just discussed, and it also covers both circuits of the heart. Now we come to discussing how the heart itself receives its blood supply. The heart's an amazing organ. It circulates blood from the heart throughout the entire body with enough pressure for it to return to the heart. Heart beats about 100,000 times a day, pumping about 8,000 liters of blood over several miles of blood vessels. And in order to do that, it needs a very good supply of oxygen and nutrients. How does it get this blood supply? It gets it via the coronary arteries. Coronary from the Latin word corona, meaning crown or surrounding. So the coronary arteries start right after the aorta originates from the heart, just beyond the aortic valve, and its function is to supply the myocardium, the heart muscle itself, with oxygen and nutrients. So anytime you have arteries that are actually originate from blood vessels, all arteries end up branching into capillaries. Capillaries end up fusing back into veins. So that's a mini circulation right there in the heart. You have coronary arteries that branch into coronary capillaries that allow the heart muscle itself to get oxygen and nutrients, and those coronary capillaries now take the deoxygenated blood into the coronary veins. The coronary veins empty into the right atrium in a structure called a hole, really, the coronary sinus. Here's a picture of the heart, looking at it from the outside. It's intact, and you can see the branches of the coronary arteries. It says that you have the left main coronary artery that splits into two branches, the left anterior descending, or as abbreviated LAD, and the circumflex. These supply blood to the front and back of the heart muscle. The circumflex is abbreviated as big C, small x. Then you have the right coronary artery. It supplies blood to the right side, bottom, and back of the heart muscle. I want to emphasize that the heart itself is a three-dimensional object with different walls that can be affected by coronary circulation. So sometimes you may hear terms like anterior wall, septal wall, lateral wall, inferior wall when describing injuries to the myocardium itself. So I want you to be aware of that. That is a three-dimensional object. That's why there's so many different studies that we can do to actually examine different walls of the heart. This diagram shows the various splits that you can have in the coronary arteries, but that is actually beyond the scope of complexity that we are going into this course. But I urge you to study the diagram and make a note of it. Here is a different diagram showing how the arteries supply blood and nutrients. Here's another diagram showing the blood supply to different walls of the heart. Here we have a pictorial representation and a diagrammatic representation of the blood supply to each wall of the heart muscle. Now we're going to talk about the cardiac conduction system. What the cardiac conduction system is a specialized system of muscle cells that create and propagate electrical impulses. If you notice on the picture here, it's highlighted in yellow, but I want to emphasize for you that the cardiac conduction system itself is anatomically indistinguishable from the rest of heart muscle. In order to figure out where these bits of cells are that are making and propagating electrical impulses, we have to do what's called an electrophysiology study or an EP study. It's highlighted in yellow here just to make it clear, but these are muscle cells that thinks that they're nerve cells. I do go into a little bit extra detail here. You don't have to know certain structures, for example, the internodal tracts and Bachmann's bundle. The feature of automaticity of the cardiac conduction system, the ability to self-excite or make electrical impulses, is a special property of myocardium. In other words, myocardium has an identity crisis. It doesn't know whether or not it is muscle tissue or nerve tissue. It functions actually as both. The pumping action is part of its muscular function, and the electrical function is where it functions like nerve. For our purposes, the cardiac conduction system will be composed of the SA node, the AV node, the bundle of His, the left and right bundle branches, and the Purkinje fibers. This particular slide gives you kind of a three-dimensional representation of the bundle branches, especially the left bundle branches. You needn't concern yourself with that because that's beyond the scope of this course. The SA node, or sinoatrial node, that's what SA stands for, is the president. He's the man in charge of the heart. It's located in the right atrium near a hole called the coronary sinus. The coronary sinus is where the cardiac veins empty in the right atrium. So it has an intrinsic or programmed rate of 60 to 100 beats per minute. Just an FYI, that is the normal heart rate range. Anywhere from 60 to 100 is considered the normal heart rate range. It creates the impulses that conduct in the atria and causes them to contract. These same impulses flow from the atria to the ventricles, which cause them to contract. Therefore, the SA node is in control of the heart. So there's no physical connection to a nerve that causes the heartbeat. It's the SA node that produces the electricity that causes this muscle to contract. If you remember when we studied the musculoskeletal system, muscles need an electrical impulse that tells them to contract. The electrical impulse in this case comes from within the heart itself. We're going to talk about the AV node. It's located in the floor of the right atrium, close to the septum. Just an FYI, the heart has a fibrous skeleton that separates the atria and ventricle, and it anchors the AV valve. The fibrous skeleton does not conduct electricity like the rest of the myocardium. The AV node is the only electrical connection between the atria and the ventricles. There are three functions of the AV node. It conducts the impulse from the SA node to the ventricles. It is the secondary pacemaker of the heart, just in case the SA node should fail. And it has a lower intrinsic rate of 40 to 60 beats per minute, and then it slows down the impulse. So the AV node is kind of like the vice president. He's in charge when the SA node does not report for duty. The reason why the AV node slows down the impulse is to give the atria time to finish contracting. Remember that a couple of things here are happening at the same time. The atria are the receiving chambers of the heart. They start passively filling up with blood. When the SA node fires off, that electrical impulse causes the atria to contract. When the atria contract, blood is pumped past the AV valves and it fills up the ventricles. The impulse is then conducted to the bundle of His, or the His bundle, where the impulse is sped up again and conducted to the bundle branches. The left and right bundle branches conduct the impulse down the interventricular septum and to the left and right ventricles respectively. Notice that the impulse goes down the interventricular septum and it starts to contract the ventricles from the bottom up. The same way, the most efficient way to get all the toothpaste out of the tube is to squeeze from the bottom up. In a similar fashion, the best way to get the most blood out of the heart is to squeeze the ventricles from the bottom up. The left and right bundle branches divide into a very finely branched network called Purkinje fibers. These fibers bring the impulse to the superior parts of the ventricles and to the endocardium. Lower pacemakers below the AV node can act as a tertiary pacemaker in case the SA node and AV node fail. They have an intrinsic rate of 20 to 50 beats per minute. The main tertiary pacemaker that we're talking about here is the bundle of His. So if we're still sticking with the government analogy, we can say that the SA node is the president, the AV node is the vice president, and the bundle of His is kind of like the Speaker of the House. Succession of power-wise. This diagram shows the generation of one heartbeat, and it's called a cardiac cycle. But remember, while all of this is happening, blood is being received in the atria. The atria is filling up. Once the atria is filled, then the atria depolarize. Depolarize means to receive an electrical impulse that normally results in contraction. 99% of the time, when the cardiac muscle gets an impulse and depolarizes, it results in contraction. So we start with an impulse being generated by the SA node. It depolarizes both atria. The atria contract, pump this blood past the AV valves, the bicuspid on the left and tricuspid on the right. Then the impulse goes to the AV node, to the bundle of His, right and left bundle branches, and starts depolarizing the ventricles. One of the first things that happen, however, is the impulse actually depolarizes the papillary muscles that causes the AV semilunar valves to close. The impulse depolarizes the papillary muscles that causes the AV valves to close to prevent the backflow of blood into the atria. Incidentally, it is the closing of the valves, the AV valves, and then the semilunar valves in the aorta and pulmonary artery that causes the heart sounds, S1 and S2. The actual contraction of the heart muscle itself is pretty silent, but what you're hearing in S1 and S2 is the blood itself hitting the valves. And this entire process takes place and generates an EKG wave. It takes place in about 0.225 of a second. This is another diagram that illustrates that everything is happening at the same time. First, blood arrives at the heart via veins. The atria fill up with blood. The SA node fires an impulse that causes the atria to contract. The atria pump the blood past the AV valves. The AV valves close because the impulse gets conducted down the AV node and the bundle of His. Then the ventricles contract from the bottom up, from the apex upward, and push the blood out of the heart into the arteries, the aorta and pulmonary artery respectively, past the pulmonary and aortic valves. Some basic cardiac terminology here. The cardiac output is the amount of blood that the heart pumps out in 1 minute. It's measured in liters per minute and is calculated by the equation heart rate times stroke volume. The ejection fraction is the amount of blood ejected by the ventricles with each contraction. Now, ideally, you would think that 100% of the blood that's received by the ventricles is pushed out of the heart. That's not the case. About 60% or better is pushed out of the heart, and that's considered a good ejection fraction. And the heart rate is the number of times that the heart beats in 1 minute, and of course it's measured in beats per minute. How can we obtain the heart rate? We can obtain the heart rate by taking the pulse. We can obtain the heart rate by listening or auscultating the heart, or we can obtain the heart rate via an electrocardiogram. And that's our next topic. Let's talk about the EKG. The EKG is a graphic representation of the heart's electrical activity. The EKG, or electrocardiogram, is also abbreviated as ECG. It gives us precise information about the heart's rhythm and the rate. It can be used to diagnose disturbances in the heart rhythm known as arrhythmias, and some textbooks call them dysrhythmias. The EKG is a quick, simple test that can be done in about 10 minutes or so. It's non-invasive, and it's usually done as a standard part of a preoperative screen. However, it can give us information that will require further testing or confirmatory testing. So we have two general types of tests in the medical field. Screening tests that are quick and easy, give us some quick information, and confirmatory tests. So any of these pathologies will require a diagnostic test and a confirmatory test. Any other pathologies would require a confirmatory test. For example, hypertrophy, which refers to chamber enlargement. You can either have atrial hypertrophy or ventricular hypertrophy. You can have hypertrophy of the left side or hypertrophy of the right side of the heart. Electrolyte imbalance. Electrolytes, again, are salts, or electrolytes are small charged atoms that allow the body to make and conduct electricity. Common electrolytes include sodium, potassium, calcium, and magnesium. Ischemia and infarction. Ischemia refers to the reduction in oxygenation because of the reduction in blood flow. It usually precedes infarction. So first you have ischemia, you have some symptoms from the ischemia, and then you have actual infarction. Infarction refers to actual injury of the myocardium itself and tissue death. Certain drug toxicities also have specific patterns of manifestations on the EKG, and other diseases such as pericarditis, which is an inflammation of the pericardium, has a specific pattern of abnormality that shows up on the EKG. Since we have billing and coding students as well as clinical students in the class, I'll introduce you to a couple types of EKGs. The standard EKG is the resting 12-lead EKG that's usually done when the patient's lying down. And there are 10 wires that are attached to the patient, resulting in 12 leads. Think of a lead as a view of the heart. Remember, the heart is a three-dimensional object located in the chest. So we're looking at it from 12 different angles to get the most information we can about the condition of the walls. The 15-lead EKG is done to determine right or inferior wall damage. The 18-lead EKG is done to determine posterior wall damage, and it can be done on neonates as well. In neonates, the position of the heart is slightly different than that of children and adults. That's why we might need an 18-lead EKG to visualize the heart better. In instances of dextrocardia or right wall injury, we might do what's called a right-sided EKG. Even though right-sided wall injury is fairly uncommon, it's still possible. Remember, the left side of the heart is doing the majority of the work. It's the left ventricle that has the thickest wall, and it's the left ventricle that has to pump blood through the body to all the body's systems. In addition, there are several different ways we can monitor the patient to get a rhythm strip to determine what type of rhythm they're in order to detect arrhythmias. We have 1, 2, or 3 leads from an EKG that are visualized. So we don't have the normal 12 leads. So it's not a 12-lead EKG. The patient's heart rate, rhythm, and arrhythmias, again, can be determined, and it can be used in hospital or it can be done on an outpatient basis. Cardiac telemetry is a box that the patient usually wears in the hospital, and the box sends a infrared signal to a central monitoring station where you have a person that's actually there that monitors several patients on that particular nursing unit. You also may have a hardwire cardiac telemetry in which there's a screen at the bedside of the patient. That's more common in the ICU setting. A Holter monitor is a monitor that is worn for 24 to 48 hours. It's usually done with 2 to 5 channels, although 2 to 3 channels are much more common. And there are some electrodes placed on the chest. They are attached to a small cardiac monitor. It's actually maybe about 1/4 of the size of a cell phone. The patient has the monitor applied in an outpatient facility, doctor's office, or hospital. The patient then takes the monitor off themselves and they return the monitor to the facility. The monitor is downloaded and a report is scanned, and a report is sent to the physician. Event monitors can be worn for up to 30 days, and these are used to detect arrhythmias that are particularly transient. In other words, the patient has some kind of cardiac symptom that comes and goes very quickly. There's a high suspicion that it may be due to some kind of heart rhythm disturbance. So the patient wears the monitor continuously for 7 to 30 days. The patient is given a supply of sticky pads, and they change it themselves, and they wear it continuously. Some time ago, the patient would have to actually activate the monitor itself and call into a call center, transmit a rhythm strip, have the rhythm strip read. Modern versions of event monitors contain a sensor that is applied to the chest that is stuck there for 7 days continuously, and a transmitter that the patient keeps with them about the size of a cell phone. The monitor continuously records. The patient can also activate the monitor, and the event itself is sent to a monitoring center via a dedicated cellular network. Examples of an event monitor include the Seek monitor or the CardioCare monitor. There are also implantable loop recorders that go under the skin and will monitor cardiac rhythms for up to 3 years. This monitor as well transmits to a centralized center in which the arrhythmias are evaluated, and physicians are alerted if there's any arrhythmias that are detected. Here we have some examples of cardiac monitors. The first one on the top left is the implantable loop recorder, and then the X-ray shows the implanted loop recorder under the patient's skin. We have a Holter monitor there with 7 leads. We have an event monitor. You can see there it has a black and white. It's only 1 channel. And we have the Seek patch that has been pioneered by Medtronic. So this is the basic cardiac cycle that shows up on the EKG. This represents 1 heartbeat, and it's made up of several different waves. The first wave in the normal cardiac cycle is the P wave. Notice it's a positive wave. Next is a series of 3 waves, the QRS complex. We have a segment that's in between 2 waves. It's called the ST segment. Then we have the T wave, and finally the U wave. Each of these waves represents something that's happening with the heart physiologically. Atrial depolarization is a fancy way of saying atrial contraction. QRS complex represents ventricular depolarization. The T wave represents ventricular repolarization or recovery. Now the U wave on the adult EKG is considered abnormal. If it shows up after a stress test, it's usually an indicator of ischemia. In pediatric EKGs, however, it may be present. It's important to note that the ST segment is where we look to see if the patient is having a myocardial infarction or MI, which usually manifests itself as ST segment elevation, or the patient may be having some sort of ischemia. Ischemia, again, is the reduction in blood flow and oxygenation in the myocardial tissue that precedes infarction. So we may have ischemic changes on an EKG that tells us that this patient has some kind of coronary artery disease. Coronary artery disease is blockage of the coronary arteries, the arteries that supply the myocardium itself. Ischemia on the EKG usually manifests itself as ST segment depression. So infarction is ST segment elevation, and ischemia is ST segment depression. Again, there are exceptions to the rule, but for our purposes, it's good for you to just know the basics. Okay, so I just want to quickly talk about the diagnosis of an MI. 85% of cases, there are non-specific changes on the EKG. In about 50 to 65% of cases, there are diagnostic changes that occur within the first 2 days of the MI. In addition to doing an EKG, there are certain cardiac biomarkers or cardiac enzymes that are drawn in the blood. Usually they're drawn in a serial fashion, something like 0, 2, and 6 hours upon admission to the hospital or upon admission to the emergency room. And these are usually troponin 1 or troponin I and CKMB or CPKMB. And it depends on the hospital's particular protocol which particular cardiac biomarkers are drawn and how often. And in MIs that show EKG changes, the most frequent EKG change is what we call ST segment elevation, and these MIs are called STEMIs or ST segment elevation MIs. In the MIs that show little or no change or even non-specific changes, they're called non-ST segment elevation MIs or NSTEMIs. You might frequently see this as a admitting diagnosis, either STEMI or rule out STEMI or NSTEMI. Again, a myocardial infarction is a heart attack, and it usually indicates that some tissue death or muscle injury has occurred. Just going to briefly talk about the normal heart rhythms because you'll frequently see this as a diagnosis following an EKG. Sinus rhythm, a regular sinus rhythm or normal sinus rhythm, they're pretty much all the same thing. That means that the SA node, that's the normal pacemaker, is in control of the heart. The heart's rhythm is regular. In other words, the next heartbeat comes when we expect it to. There's a regular interval between the heartbeats. The rate is between 60 and 100 beats per minute. And again, that's the normal heart rate range. Sinus bradycardia, the SA node is in control of the heart. There is a regular rhythm, but the heart rate is slow and it's below 60 beats per minute. So what might be some causes of sinus bradycardia? Sinus bradycardia is usually a normal variant of sleep. We also see this in trained athletes whose hearts are much more efficient pumps. They can do the same work as a non-trained athlete, just at a much lower rate. A lot of students think that trained athletes, their heart rates are going to be higher, but that's incorrect. Resting heart rate in a trained athlete can be anywhere from the 40s to the 50s because they can pump just as much blood in your body at a lower rate. Sinus tachycardia. It's called sinus tachycardia again because the SA node is in control of the heart. If you see a common theme here, anytime the sinus node is in control of the heart, the rhythm is named sinus something. Okay, so sinus tachycardia, the heart rate is regular, the rhythm is regular rather, but the heart rate is above 100 beats per minute. So what might cause some sinus tachycardia? Well, exercise, for example. Emotions is another example. But common causes in hospitalized patients would be fever and pain. So fever, because the body is trying to dissipate the excess heat, causes the heart to circulate the blood at a faster rate to try to get rid of this heat. And of course, pain usually causes the release of epinephrine, and that has an effect on the heart rate as well. Sinus arrhythmia. The SA node is in control of the heart. The heart rate is between 60 and 100 beats per minute. but the rhythm is irregular. It does follow a breathing pattern. What happens is when the patient inhales, the heart rate gets faster. When they exhales, the heart rate gets slower. We commonly see this in children. It's considered normal up until the early 20s, sinus arrhythmia. Let's talk about some rhythm disturbances or arrhythmias. Atrial fibrillation is far the most common rhythm disturbance in the United States. We have irregular rapid heart rhythm that predisposes the patient to clot formation. This can be a chronic condition. It can result in episodes of tachycardia as well as pauses in the heart rhythm. How do we treat atrial fibrillation? Well, if we're going to medically manage atrial fibrillation, that means via medication alone and no interventions, we have to give the patient 2 medications, at least. One set of medications for the rate control so that the patient's heart rate doesn't get too fast, and anticoagulants to prevent clot formation. What fibrillation really means is that the atria, instead of contracting and pumping blood to the ventricles, it actually quivers or twitches, and we get pooling of blood in the atria. Anytime we have pooling of blood anywhere, there's a tendency to form clots. There's also a procedure called DC or direct current cardioversion to treat atrial fibrillation. Basically, it's a synchronized shock that is supposed to put the patient back into normal sinus rhythm. There are also some surgical procedures that are meant to address atrial fibrillation, one of them being the Cox-Maze procedure. Atrial flutter. It's a rapid rhythm in which the P waves are replaced by sawtooth-looking F waves. Treatment for atrial flutter is direct current cardioversion, or what's called radiofrequency catheter ablation. Ablation is usually done in the electrophysiology lab, and we take a catheter, put it into the patient, we do an EP map of the heart, figure out where this ectopic rhythm is coming from, and you kind of cauterize that tissue. Usually radiofrequency kind of cauterizes the tissue. There is another version of ablation, it's called cryoablation. Radiofrequency uses heat, cryoablation uses cold to get rid of the tissue that's causing the problem. Ventricular tachycardia. Ventricular tachycardia is one of the potentially life-threatening rhythms. The ventricles are going extremely rapidly, and that's where the impulse to contract the heart originates. So it's not pumping very efficiently. Actually, some forms of ventricular tachycardia are pulseless, and we treat ventricular tachycardia based on whether or not the patient has a palpable pulse. This rhythm can lead to death. Loss of consciousness is frequent. If we don't treat this with lidocaine, procainamide, or in cases of pulseless ventricular tachycardia, shock the patient out of it, the patient can die because ventricular tachycardia will lead to ventricular fibrillation. Ventricular fibrillation, also known as VFib. The patient is dead. If the rhythm is not reestablished, brain death is imminent. It's a chaotic, irregular quivering of the ventricles. In other words, those are the pumping chambers, so no blood is being pumped. The treatment for VFib is to defib, to defibrillate the patient or shock the patient. And of course, in between, CPR so that the brain continues to receive oxygen. And to continue CPR so that the brain receives oxygen. So heart block is a condition in which there is a blockage of the electrical signal. Please don't confuse it with coronary artery blockage.